Not often do I have this kind of opportunity to come out as a former shelter and housing director in Wisconsin, so it feels like a safe place to disclose that to you. And it feels important because it's actually a critical piece both in terms of my own professional development and entering into managed healthcare, which I spent so many years as an advocate and a social worker on the streets demonstrating against systems of care that I felt did not afford the kind of access and availability and support that could be possible. So the Amita Care sponsors, all 6 of them, have a history also in terms of HIV/AIDS, but also housing and supportive care. Jason mentioned Harlem United, but Housing Works, Promesa Basics, Village Care, St. Mary's are all partners of ours in Project Samaritan in the Bronx, who brought to the table this emphasis about thinking about the whole person. So a SNP, by definition, and the credit for this really goes to the AIDS Institute and the Medicaid office, of saying that we should build, a SNP should be a comprehensive health plan. So not just medical, which are the things that you pay for, but you are required by contract to also deal with the non-medical issues, of which housing is really the primary key issue. But it doesn't really stop there. You've got support, you've got transportation, you've got legal services, benefits, jobs, and education, which a special needs plan can actually be creative in thinking about the whole person. So for us at Amita Care, what became very clear in the beginning was that if all we did as a health plan was pay claims, as fast, hopefully, as Medicaid, but if that's all we did on the provider side, and on the consumer side was we told people to go to the doctor's office and take medications on time, we were contributing very little to the transformation of the public healthcare system. So our early beginnings were really focused on talking to providers and talking to consumers about what they would want in our health plan. And one of the things that providers said was obviously you need to make care accessible, facilitate access. But the other thing we heard over and over by providers was we really need help with the individuals who drop out of care and who aren't actively engaged in either OMH, targeted case management, or COBRA case management. Those individuals who've dropped out of the system. And in the HIV/AIDS world, many of the individuals had access to supported housing through HASA. But when we talked to HASA case managers, what we heard was folks don't have a true medical home. They're getting scripts filled in emergency rooms. And there's lots of undertreated behavioral health, largely substance abuse issues. So a little bit about just about our membership. 90% of our members report hard drug use histories, and between 20 and 30% active use. 40% of our members have reported experiencing homelessness since their HIV/AIDS diagnosis. So what has the SNP model achieved in terms of outcomes? For our plan, 92% of our members are engaged in regular outpatient care. Okay? So the idea that people who are actively using substances cannot engage in care and have access to medications and participate is a lie. It can be achieved. The devil is in the detail of how you accomplish that. 95% of members get regular substance abuse screening and mental health screening. The results of the SNP model, higher quality health outcomes, are what have driven cost savings in the HIV/AIDS world. Just a little bit of details. 15% cost savings in SNPs over fee-for-service, unmanaged fee-for-service between 2003 and 2008. How was that cost savings achieved? Hospital admission rates fell by 25%. Average length of stay in the hospital was reduced by 15%, and SNPs increased outpatient care and pharmacy utilization. So pharmacy utilization went up by 5%. Why? Because people were in regular outpatient primary care services where their HIV/AIDS was being monitored, and they were able to work with their providers to actually take advantage of newer medications and treatments. So if the devil's in the detail, what's the detail? What have we learned about our process since opening in 2003? The very first fundamental principle, I think, in the SNP model is that the member and the consumer must participate in the governance of the health plan and in the direction of the operations. So almost 25% of our board of directors are members of the health plan. Those individuals are actually elected from a core constituency of member leaders who are elected from their primary care sites. So we have a member advisory council who comes together and then makes the recommendations from the consumers, from the members of our plan, as to who should represent them on our board of directors. That, to me, was radical when I got to Amita Care, that there was that much understanding that we should involve consumers in the running of their health plan. We meet about 8 times a year, and that member advisory council has actually developed some of the special programs that I'm going to spend a few moments talking to you about. The other thing that members said, quite frankly, to me, was we want you to understand that you work for us. So I said, well, what does that mean? I think I agree with you, but what does that mean? And our members said, we want to see you. So we want you to come out to care sites twice a year to hold town hall meetings so that we can give you and other executives at the health plan feedback about how you're doing. Radical idea, right? That we shouldn't wait till someone complains about service. We should actually go out and create a feedback loop so people could tell us what's going well and what's not going well, and make recommendations. And one of the things that happened there was people actually told us, you know, when I was in fee-for-service Medicaid, I could see this provider, but I can no longer see this provider. They're not in your provider network. So we took down the provider's name and contact information, and then we went out and did some due diligence, and if they were quality Medicaid providers, we extended a contract and bought them into the plan, again, because consumers and providers said that access was critical. Some of the special programs that members really talked about. And let me say this. This is really about helping people with high needs, chronic comorbidities, to be in connection with the healthcare system in between medical visits. So we created a program named by our members called Live Your Life. And one of the things that in the early conversations members said to us, when we asked, what's important to you? What do you need from us? What people told us over and over again was, help me to create a great life. Not teach me about medications or tell me who to go to or knock on my door. People said, help me to build a great life for myself. So we actually went out and secured private funds to augment, I think at this stage of the game, Medicaid. We didn't have the Medicaid leadership we do now. People weren't thinking innovative. So we actually secured private funding to create this Live Your Life program and brought members together on a monthly basis in 2 boroughs to do things that were healthy, that build good health skills, health literacy and skills, provided socialization opportunities so people weren't isolated and alone. And so we have, and the other core principle was people said, you know, we're a pretty diverse mix of members. And we want to learn about other cultures, and we also want to be able to share with others the true gifts of our culture. So this program includes sacred African dance classes, we have salsa dance classes, we have a yoga class. People said when we changed the name from Amita Care to Amida Care, people said, where did you get Amita Care? And Amida actually has several Sanskrit as well as Hebrew traditions, and it really, the meaning of Amida is to stand up with and for. So there's actually a prayer in the Jewish tradition that you must stand for the Amida. So the core principle about this was to stand with members, for members, in ensuring that people got care and services that helped them to be well. And if we achieved that, we would save money. We have biannual life celebrations. Members come together, give personal testimonies, speak to other people, become innovators with other consumers about, I was there, this is where I am now, and you can do that too. In terms of our care coordination model, we have lower primary care provider to patient ratios, right? So many managed care systems have thousands of patients connected to a single provider. One of the things that you can do in the special needs plan model is you can actually lower those ratios so that providers can spend more time with patients and do all of the kinds of things that actually build good health-seeking behavior and actually communicate to the consumer, no, I want you to come back and talk to me about medications. No, I want you to talk about the issues that you're struggling with and really make this truly your medical home. Our nurse care coordination staff, actually, one of the things that providers said was, when we can't get an early enough appointment, we want to be able to call up your plan, and we'd like your staff to dial your network and see if you can find us an earlier appointment. So our nurse care coordinators are backups to care systems to actually find earlier appointments. Our internal behavioral health unit is actually responsible for finding a detox rehab bed that is available now and coordinating transportation, because we all know when a consumer says, I'm ready for that service now, you really need to be responsive now. You can't say, I'll get back to you tomorrow, the next day, or the third day. You will miss that opportunity. We built a retention and care unit, which is staffed by social workers and outreach workers and peers. About 50 members of our health plan have part-time jobs working within our retention and care unit. And the idea is that if someone drops out of care and is unresponsive to phone calls and letters to come back for a visit, that we don't wait for people to end up in the emergency room or get readmitted to the hospital. We actually send a team out to find those members who've dropped out of care. Peers conduct home visits, professionals conduct home visits, and then to actually talk with people like, what's going on that you've dropped out of care? You're not satisfied with your provider. Let's look at your provider directory about your options for new care relationships if you're truly unhappy. But let me ask you, before you change your care relationship, did you tell your existing provider that you were dissatisfied? And many consumers will tell us, no, I voted with my feet, right? The Medicaid card for a long time has been a source of personal power for individuals, and people have learned one way to use that personal power. And so the innovation, and I think where we are today in terms of working in managed care systems, is to actually help consumers to understand that yes, they have power, but they have choices in how they express and use that personal power. In the last 16 months, we have outreached, identified through our own claims system, 934 members who we've identified as either unconnected or they've dropped out of care. Now, I know this is a radical concept that a health plan would identify people that they're not spending money on and actually send people out to go find those individuals to bring them in care so they could spend money on care, right? So here's the results. We've outreached 934 individuals, and within a period of 6 months have been successful at reconnecting those individuals to a true medical home, 80% of them. Over almost 3/4 of them are now getting routine quality of care measures for HIV mental health care, and 83% of them are taking HIV medications regularly and or behavioral health meds. So the last thing I want to tell you about is that in addition to sort of working differently with consumers, we went and sought out Social Innovation Fund money to work on system redesign, the care system, right? So we got about $1.2 million to actually work with primary care programs to assist them in the redesign of their practice management that would actually, those of you that run clinics, right, folks have no-show rates. So what's a typical response to high no-show rates? What do you do if you want to keep your clinic financially viable?
Improve the service.
So you might improve services, but the more typical answer that I hear from clinic managers is we need to double book. Sort of like the airline response to a major problem in the healthcare system. And one of the things that we've actually done is to work with those lead agencies, those providers, to redesign their practice management to actually create open access and same day, next day, and third day appointments, so that when we outreach to people and we actually promise them that we could bring them back into care and make it meaningful, that we're actually able to deliver by having systems out there in the community that could actually see that person on the same day. So these are just some of the things that I think are possible within a special needs model, and I'm happy to be able to share with you. Thank you.